Good morning and welcome to Health Talk, sponsored by Mon General Hospital. This program is designed to provide education on vital health topics to help you take charge of your health. You'll also be introduced to Mon General's committed physicians, allied healthcare professionals, and quality programs and services. And now, here are your Health Talk hosts, Kay Murray and Jim Stallings.
I am Jim Stallings. Kay Murray is off today. This is Health Talk, brought to you by Mon General Hospital every Thursday morning at 8:35 here on WAJR. The topic on today's program is diabetes with internal medicine physician Dr. Farzaneh Hassaneh. Good morning and welcome to the program.
Good morning.
Today, again, we're talking about diabetes. So what is the definition of diabetes? It says here the epidemiology of diabetes, but I have no idea what that means. So what is diabetes?
Well,
talk closer if you don't mind.
Sure. Diabetes is a very prevalent disease in the society, unfortunately, and it's about 8% of the total population of Americans are affected by diabetes.
All right. Why America and not Japan, for instance?
Well, Japanese are catching up as well, but they do have a slightly healthy lifestyle than Americans do.
The adult onset diabetes, the diabetes type 2, I've heard it referred to as a fat guy's disease or a fat person's disease, because if somebody gets the type 2 diabetes, they're generally in a character type of being overweight. Is that a correct generalization or just a bad generalization overall?
That's pretty much correct, unfortunately.
All right. So what is it that the problem is with insulin and the pancreas not producing enough insulin to absorb the sugars? Is that correct?
Well, part of it. But the main problem is that there's insulin resistance. That's really the main reason for type 2 diabetes. What that means is that your pancreas is still producing insulin, but your body does not know how to utilize the insulin. But in type 2 diabetes, usually at the time where you're diagnosed with diabetes, 25% of your pancreas is already gone. So you only have 75% of your pancreas left. So it's a combination of not having enough insulin and at the same time not being able to utilize the insulin you already have.
So can the pancreas only produce a certain amount of insulin and it just can't get to all of the cells in the body if we're overweight?
No. The amount of insulin that is produced, it gets distributed to the whole body. But for some reason, unfortunately, people who are overweight, they lose that sensitivity to insulin. So they still have enough insulin around, but the body doesn't know how to utilize that insulin to lower your sugar.
All right, so a lot of people who develop the type 2 diabetes adult onset don't know it, I think, in the early stages, right?
Correct.
Usually it takes some kind of trigger or something that is out of whack or abnormal, probably, to get them to go see their doctor. The doctor does a blood test, finds they have sugar elevated. So what are some of those common signs that people have if they have diabetes but they haven't been diagnosed with it yet?
Right. A lot of symptoms are very non-specific. One of the symptoms that is extremely common that I hear all the time in my practice is fatigue. They just feel more tired than usual. There's symptoms that you usually read in the books or journals or something, whether they have increased thirst, increased urination. Those usually happens when your sugar is really high. We're talking 300, 400, and that's the time that probably a lot of damage has been done. So the best thing to do would be, as soon as you feel not right, you have a family history of diabetes, that should trigger it for you to see a physician to get your sugar checked to make sure that is not causing the problem. We have had people that they have a sudden vision loss, and they go to the emergency room, their sugar is 700. So there is a lot of different symptoms that can present. The best thing to do truly is go to these multiphasic health fairs that they have everywhere, and it's very cost effective, and get your blood work done maybe once a year. If you can, maybe twice a year. Once a year is pretty efficient if you don't have any medical problem, but if you get it more frequently, it's even better.
What's the normal range of the glucose reading now?
Ideal is less than 100.
But the average or the above number, it was 120. Is it 130 now?
No.
It's still 120?
Well, 126 and above in 2 different occasions fasting is diagnosis of diabetes. So your sugar between 100 to 125 is where we try to watch it, or people call it borderline diabetes, which really is a misconception because there is not such a thing as borderline diabetes. Because if your fasting is between 100 to 125, I assure you that your postprandial glucose, which is your 2-hour sugar after you eat, is definitely within a diabetic range.
Yeah, you talk about the fasting sugar, and I want you to elaborate on how important it is to get a reading from that, because the way the body processes food after you eat it, you naturally get a spike in your glucose level after eating, right?
Yes, you do. Everybody has a spike of glucose from the time you eat up to 2 hours after you have eaten. Generally speaking, if you are a healthy individual, 2 hours after you eat, your sugar should be down to baseline. But if you have a persistently high sugar, which lasts anywhere from the time you eat to, let's say, 4 hours, you definitely have some glucose intolerance. That's the group of people that is the hardest to diagnose because their fasting is going to be normal, but those are the people who are going to suffer the complication of diabetes, and by the time you find out, they've already had the effect on their eyes, they already have the effect on their kidneys.
Yeah, so the elevated sugar staying in the system for a long time, above 200, 300, that I know starts to affect your arterial nervous system, or actually your blood flow to your feet.
Right.
It also affects your eyes.
Yes.
So even though I keep thinking that sugar is glucose and glucose is sugar, but the sugar we take in isn't necessarily sugar that's in the body, right? I mean, it's converted into
glucose. The form of sugar that the body utilizes is glucose. So no matter what kind of sugar you eat, it's going to be converted to glucose, and the glucose is what's going to harm your body when you have too much of it around.
I see. And so it can affect your eyes, can affect your feet. We can get into a whole topic on that if we need to. But again, we're talking about diabetes today. When it comes to diagnosis, it sounds as though the sugar testing on a fast and not eating, that is the diagnosis. I mean, you said if we're consistently above 126, we have diabetes.
Correct. Fasting.
So there's not much more with diagnosis. Anything additionally?
Well, what you could do is that I talked about the group that you want to have early diagnosis, the one that people call it borderline. In order to diagnose that group of people and hopefully start some form of treatment, whether it is lifestyle changes or medication, it is always a good idea to either have what is called hemoglobin A1C, which can be measured every 2 months, or 2 hours after you eat, check the sugar. If 2 hours after you eat is above 140, or if your hemoglobin A1C is above 6.5, by definition, that's diabetes.
Right, because the A1C is pretty much a snapshot of the previous 2 or 3 months, or
Correct.
maybe 6 weeks or something like it. It's a snapshot of your overall glucose control.
Right.
The meters where you poke a little hole in your finger and draw the blood that way, that's just a picture of your current blood glucose level or the previous 12 hours.
12 hours,
so
yes,
to speak.
that is
All right.
correct.
304-296-0041. If you have any questions and you'd like to join in the Health Talk program, you're welcome to do so. Brought to you by Mon General Hospital. We'll be back to discuss more about diabetes right after this.
This is Mon General's Health Talk, providing the information you need to take charge of your health. Call us now with your health-related questions at 304-296-0041.
Internal medicine physician Dr. Farzaneh Hassaneh is our guest today, and we're talking about diabetes on the show, and you're welcome to ask any questions at 304-296-0041. Well, we talked that the type 2 diabetes can generally occur in people that are a little bit overweight, but are there genetic factors in the type 2? think there are in type 1, but what about type 2?
Yes, there is. If you have a family history of type 2 diabetes, you're at more risk for developing diabetes.
Right. So does that mean that we should know whether or not our grandparents had diabetes?
Correct.
So risk factors include heredity, being overweight, lifestyle. Is it what we eat?
Sedentary lifestyle.
Couch potatoism.
Yes.
Yeah.
Yes, absolutely. And also being a female is an increased risk for diabetes, unfortunately. If a woman has a history of gestational diabetes or had babies greater than 10 pounds, they're at more risk for diabetes. If you have other comorbidities, if you have your good cholesterol, the HDL is less than 35, or if your triglyceride is less than 250, you're at more risk for diabetes. And if you have peripheral vascular disease or if you have hypertension, those are all the risk factors that can play a role in developing diabetes.
The race or color, is there any difference between
Black
races
Americans
and colors?
are at more risk, Hispanic are at more risk than white people.
And we probably don't know why, right? I mean,
Not really.
does
No.
anything to do with diet?
I don't believe so.
Those are the kind of things that I wonder why, Hispanic people have more incidences of diabetes than Caucasians, or black males opposed to black females as opposed to white females and white males. That kind of stuff fascinates me. But again, it's probably because we don't know the answer. So let's talk about treatment. If we're on that above 126, and you said we really shouldn't call it borderline diabetes, it either is or it isn't. But
Right.
if you have 130, consistent 130 readings, as opposed to somebody who has the 2, 3, 4, and you said there are people with 700. I've never heard of that. But
Those are usually people who don't know they have diabetes,
yeah.
and they just get sick and they go to the emergency room. That's the type we usually see. In the office, we hardly ever see sugars of 700, thank goodness.
But there has to be different treatments for the 130s compared to the 230s.
Yes, there is.
Okay, so talk about the lower end, the treatments, and then go into some of those higher numbers, what people are treated with that way.
The way you want to treat diabetes is, of course, lifestyle changes are your first thing you want to do. Definitely exercise, average about 150 minutes per week, and it doesn't have to be high pace. It can be low pace exercise. Weight loss is extremely important. If you be able to lose 7% of your total body weight, can improve your control of your diabetes and other comorbidities. And if a patient fails to do that, then obviously you need to start treating with medication. If you remember, I mentioned about insulin resistance initially. So one of the important medications you want to use is to improve your insulin resistance. One of the first line medications that we use is metformin, which has been around for a long time. It's extremely safe medications, very minimal side effect. It helps with the control of your blood glucose as well as lowering your insulin resistance. If a patient fails metformin and lifestyle changes, then you want to add what we call a second line treatments. The second line treatments are different type of medications and different classes. We've all heard different names, like, for example, Actos or Evandia. Evandia was on the news for a long time, and unfortunately we don't use these two medications too often anymore, mainly because of different side effects associated with them, but they are extremely good medicines for treatment of diabetes. And but eventually you may have to have medications that increases insulin release from the pancreas. The first and most important one is a group of medication called Sulfonylurea, which they've been around for a long time, and their side effect is very clean. They do have a side effect of weight gain, unfortunately, which is true to most diabetic medications, with exception of very few. Sulfonylurea would stimulate your pancreas to produce more insulin. And there are glyburide, glucotrol. Those are the few that a lot of physicians use. Patients know about them. There is one in the group called Glimepiride. That's the generic name. The brand name is Amaryl, which not only improves secretion of insulin from the pancreas, but it also helps slightly with insulin resistance. So that is what I use the most in amongst all the sulfonylureas. Now, again, if a patient fails this, then the next step would be few other medications that we have. Of course, insulin is one of the important ones. It's been around for a long time. It does work. And there are some newest studies that a newly diagnosed diabetic, if you treat them intensively with insulin, you may put them into remission, and then you just monitor them, and if their sugar starts to go back up, then you start treating them. So insulin is a very valuable medication. There's lots of other new ones in the market, things like Januvia or Onglyza, Tregenta. Those three are in one class, and they help tremendously with what we call postprandial hyperglycemia, because they work on the enzymes which is responsible for elevation of your sugar after you eat. Very good medicines, unfortunately very, very expensive medications.
Those are the flex pens that are advertised?
Flex, that's not a pen, these are pills.
Okay.
The pens are Byetta and Victoza. Those are what we call a GLP-1 analogs, and they are also very good for lowering your sugar after you eat. Byetta is twice-a-day injections, and Victoza is once-a-day injection. You could use it anytime during day. The only drawback with them is that, number one, they're expensive. Number two, lots of people, they're very reluctant to inject themselves with anything, but they're very easy to use. As you said, it's flex pen. The needles are very small, very short, so it really doesn't hurt that bad.
If you are started out on metformin years ago, does the efficacy of that wear off?
No.
You can continue to take that
Yes.
as long as you need to.
Yes.
There's also some kind of pen called Novolog. Is that similar to the Byetta, or?
No. Novolog is actually insulin. Byetta and Victoza is not insulin. There is Levemir and Lantus. They're once-a-day insulin. In some patients, you have to do it twice a day, and those are called basal insulin. They're designed to mimic your body response to sugar. And then we have the long-acting insulin, which the commonest one is NPH. And then we have short-acting insulin, Novolog, Humalog, or Humulin R are the short-acting insulin. The short-acting insulin are usually timed between 20 to half an hour before you eat. And if you want to be a good diabetic patient, really, you should check your sugar 4 times a day. And based on what we call a sliding scale we hand it to the patient, then you use your short-acting insulin. That's where your Novolog and Humalog comes into play.
So that could keep your glucose from spiking after eating?
Yes.
Okay.
Absolutely. And we also have combination. There are some insulins that are a combination of long-acting and short-acting insulin. We have Humalog 75-25, or we have Humalog 50-50, and there is Humulin 70-30. So depending on what your patient's needs are, if somebody doesn't want to check their sugar 4 times a day to use the regular insulin, you could use combination.
Yeah, you've just proven the point. Don't try to look it up on the internet and medicate yourself. You need the doctor's help, that's for sure, to find out exactly what's right for you. But when we come back from the break, we'll talk about specifically how they treat diabetes at Mon General Hospital. We'll be back right after this.
The doctors, the latest news and procedures. Your local health connection is Mon General's Health Talk. If you'd like to be on the show, call 304-296-0041.
Welcome back to Health Talk on WAJR, brought to you by Mon General Hospital. And Dr. Farzaneh Hassani is our guest today, talking about diabetes. So services available at Mon General Hospital when it comes to treatment of diabetes. What can you tell us?
Well, one of the best programs we have at Mon General is our diabetic education classes, which generally every patient with diabetes should attend diabetic education classes at one time through their life, or even more often if their insurance allows. We have a nurse educator, we have a dietitian on the service, and they can teach them about lifestyle changes. They can even teach them about their medications, administration of insulin, different types of insulin that is available. It's extremely useful program. Personally, all my patients, they go through diabetic education classes at Mon General.
And there's probably a lot of resources online when it comes
There
to
is.
diabetes.
One of the best what online can help you is your lifestyle changes. And one of the things lots of people are confused is what a diabetic can or cannot eat. One of the online services which is free, it's available to public, is eatright.com. If they go to that site, they teach them about different combinations of food and calorie or the type of food.
Thank you so much for all the information today.
Thank you for having me.
And again, you can find more by starting at mongeneral.com. Mon General Hospital is the sponsor of Health Talk every Thursday morning here at 8:35. Thanks to Dr. Farzani Hassani being our guest on the program today. Also, Greg Keeley, who organizes and helps produce the program. Stay tuned for news next. Then it's Morgantown AM on WAJR.